included just an awesome of Valley View team members here today who are incredible experts in what they do here with our patients and our community. So grateful to have each of them taking time from their busy schedules to be part of this conversation. And I'll go through and introduce them each individually. I'm also really excited to have my colleague here, Rob Nelson. Rob is a leader here at Valley View in many fronts. He works with internal medicine as a PA and then also leads quality and safety at Valley View. So what we do here at Valley View, we bring our mission and a tremendous amount of compassion to care for our patients. Indeed, caring for you and your family one patient at a time is our mission. This is what brings us to work every single day. The Valley View Code serves as basically kind of our values and the ethics. And if you look at that figure on the slide, you can see it's all about putting patients first. So how through quality, safety, service accountability, community, and teamwork are we always making sure that patients are at the core of everything we do? And I'm going to turn it over to Rob because I think something that is so ingrained and part of what we do is creating a culture of safety. So Rob, can you just share with the community and the group here how we live that culture of safety every day?
I would love to. Thank you, Stacy. I'm thrilled to be co-hosting with Stacy for this event and really get a chance to get the community voice. I feel like we make efforts to do that day in and day out, but it's nice to sometimes pause and just have a dedicated opportunity like this. So thanks for joining us. As Stacy said, I'm a physician assistant at our internal medicine practice where I specialize in diabetes care. And I also work as the executive director of quality for Valley View, where safety is one of the big roles. And so I just wanted to share a safety story, as we often do, start our meetings at Valley View with a safety story and really foster that culture. So what I wanted to share was fairly high level with the group today, and just the concept of preoccupation with failure and huddling around safety. So what does it mean to huddle? Huddle is a dedicated, protected time with a group. And I'll talk about what those groups look like at Valley View and the settings, but a dedicated space and time to talk about safety. And safety can be a tricky thing to talk about because, as we often say, safety is a non-event. We put a lot of work and energy into preventing harm, but that's not always obvious on the surface. When you see something that is omitted, it's not always appreciated what goes into that work. If you clean your house or you clean your car or something like that, and it just looks nice, it's not intuitive to always think about the work that you put into that. And I think it goes also for safety. So huddling is one of those examples that we can talk about in concrete fashion, where we create anywhere from 5 minutes to 10 minutes, maybe 15 at the most, but on a regular cadence. For a lot of our departments or clinics, that's a daily cadence. For some of our departments that are 24/7, like our emergency department or our laboratory or many other examples at Valley View, they actually huddle more often than once a day. It might be once a shift, which might be 2 or even 3 times per day for that dedicated time and space to talk about safety. That might be recent concerns that they've had or one-off things to be aware of or house-wide items. And so we also do, on the house-wide note, a house-wide huddle where multiple departments on the inpatient side, as well as representation from our clinics and ambulatory departments, get together for that same opportunity to huddle. And we instill tools that we use in an objective fashion in how we discuss safety at those venues. So everyone on the call is very familiar with that. And if questions come up around what that process looks like for our various departments, I would love to talk more. But for the sake of time, we'll keep moving. And I'll hand it back to Stacey for our next steps with our presenters.
All right. Thanks, Rob. So wanted to just, again, establish some of the context. We're going to spend the balance of this meeting really honing in on 2 areas. And these are areas that came out of our community health needs assessment. in 2021, we asked the community, share with us, what are the concerns you have about the health and well-being of our community? And we had a phenomenal group, some of whom are here today, and we're grateful for your continued participation and collaboration. So it was not only general members of the community, but other agencies and organizations, Mountain Family Health Centers, our local departments of public health. We all had this process where we came together and talked about what are these prioritized needs for the community. And then at Valley View, we looked at those needs and said, as Valley View, given our mission, our expertise, where can we really lean in and make a difference? And those two areas, as you see on the screen, are coverage and total cost of care and behavioral and mental health. And so we have an implementation plan that we've been working through. And again, this is an implementation plan that not only is worked through on a daily basis, but again, is part of these collaborations with the agencies that were not only part of this community health needs assessment, but many more with whom we collaborate every single day. So that is the background on our community health needs assessment. So you'll hear more about that. But I'm going to turn it back over to Rob to talk about the hospital transformation program. Rob.
Perfect. Yep. And, just to piggyback on what Stacy was saying, I would kind of say there's three big motivations for Valley View putting on this event each year. The first is really, we're genuinely interested in the community voice on feedback for the direction that we go. It also is an expectation for some very important programs with which we participate, that community health needs assessment, and the more recent program from the state of Colorado is the hospital transformation program. So we gave a little introduction at our town hall meeting last year, for those of you who may have been on that call as well. But it's a 5-year program, and we're about a year and a half into that 5-year outline. And the goals are kind of slated on this slide for what those objectives are. And I can say that at Valley View, we very robustly engaged with this process to enhance care, not just for Health First Colorado members, which is Colorado's Medicaid health insurance program, but really as a proxy to optimize care for all of our patients and enhance the services for all of our patients. And within that hospital transformation program, if we could go to the next slide, please, then it's demonstrated what kind of those concrete items at Valley View are. At the start of this program a couple of years ago, we had some say in which measures we enrolled in. 6 of them were at the state level, meaning those were chosen for us. And then the others were somewhat up to us. And we really optimized which ones we selected around our patient needs and our community needs. So these are the 10 that Valley View is engaged with over that 5-year period. And I will say that we did strive for a couple of additional measures than we were even required to, because we felt that they were so meaningful. So I'm not going to talk through each and every one of these because there's so much that goes into all of them, but we are going to highlight a couple as we're talking through slides to come. And then again, as this presentation's focus goes, I would really invite any questions or feedback from community members. So let's go to the next one here. This is just the outline for the hospital transformation program, kind of demonstrating in a little bit more detail what that 5-year process is. We are in the middle of year 2 right now, as it follows the fiscal calendar that the state of Colorado uses. So starting October 1st of this year, we will begin our program year 3. And that's really where we get into the meat of the performance measures, if you will. Thus far, we've demonstrated a lot of process measures and work that we're pouring into these performance measures. But each of those 10 metrics that you saw has associated with it expectations for benchmarked performance. And I think Valley View is well poised to perform well in this program and demonstrate not just to the state, but again to our community, our dedication to health outcomes and partnering with those that we live and interact with on a daily basis.
Great. Thanks, Rob. So now we're just going to pivot a little bit to start connecting with some of our amazing colleagues here. So behavioral and mental health, that is one of the health needs that we are addressing. And more specifically on this slide, we talk about 5 kind of key areas, key strategies in terms of how we're responding to this community need. And what we're going to do for the next section of the meeting is do a deeper dive. And starting off with Barb Cochran, who is a behavioral health provider at Women's Health. Women's Health is part of Valley View's network of care, and fantastic practice, OBGYNs, certified nurse midwives. And Barb has incredible insight and expertise in regards to that second bullet point, our work to enhance the integration of behavioral and physical health care. So with that, I'm going to turn it over to Barb. Hopefully, Zoom will cooperate. There she is. Hi, Barb. Yeah. Thanks so much for being part of the conversation today.
Of course. Just to clear, I like to kind of clarify when we talk about behavioral health, we're really talking about combining substance use disorder treatment and mental health treatment. In the past, those were sort of siloed into 2 different areas. I've been an addiction counselor for a very long time, and I think this change in language is really one of the most important things that we're doing. And then on top of that, looking at the interconnectedness of behavioral health and physical health in primary care, or in our case, in an OBGYN clinic, where we're really looking in terms of community health about impacting an entire family system. When we have a mom coming into our clinic, a new mom, and then we're able to screen for depression, anxiety, substance use. We also look at social determinants of health, which is things like, are you safe in your home? Do you have enough food for your family? Is your housing secure? Is your housing safe? Is there violence in your home? We're screening for all those things, and then really reaching out to all of our community partners. So that includes Garfield County, Eagle County Public Health, and Departments of Human Services. We partner with the Women and Infants and Children Food Nutrition Program, Great Expectations, our family visiting program, Valley Settlement, another wonderful nonprofit that helps us support families new to the Valley, the communities that we serve, and Mountain Family Health Centers are kind of our big partners in this area. And what this really means is that we're taking care of people's mental health, their physical health needs, but also just the things that we all need to stay alive in the world and to take care of our children and grow and thrive. So the exciting part of this is Valley View just received a significant grant from the state of Colorado to expand the work we're doing in this area by hiring some new positions. We've also recently hired behavioral health providers in a couple clinics where we had struggled to hire them previously just due to workforce issues. So I think lots of exciting things happening in this area. And I'll be happy to answer questions at the end if anybody has them. I love talking about this. Thanks.
Great. Thanks, Barb. So yes, we're going to pause and ask for questions of Barb, but first I'm going to have Amy Johnson speak about zero suicide. Amy, are you with us?
I am. I'm here.
Fantastic.
Can you hear me all right? Okay,
yes,
perfect.
we can. All right, turning it over to you. Tell us about zero suicide. There is hope.
Yeah, there is hope. And I work closely with Barb in this committee also. So there's a lot of interconnection between our outpatient and inpatient work around zero suicide. Key things I just want to highlight. Recently, we've done education to all staff members around gatekeeper training. And basically that was just around identifying people that are struggling and how you connect with them during those times and get the help that they need. So all staff from registration to EVS to facilities, everybody was assigned this training program so that we can bring more awareness to depression and suicide. In September, September is Suicide Awareness Month, and we are planning, Barb is also helping me find a provider to bring in to speak to all of our providers here at Valley View Hospital to just keep this topic in front of them and how we can continue grow and help reduce the suicide rates here in Garfield County. So screening and patient education enhancements include the Columbia screening tool with the triage points for all our outpatient clinics when they have somebody in their clinic and are trying to decide how best to care for that patient. We are working on that in our committee right now. We also added lethal means, which is just reduction of means for suicide when we do a safety plan for people that we're discharging from inpatient or the ED. So that's a lot of our work right now that we're working on. Just recaps from last time we talked, we are part of the state's follow-up services, which means we offer caring contacts for our inpatients that are here for behavioral health needs. And we've had 41 patients that we've referred to these follow-up services that allow people that basically that they have somebody that reaches out to them and checks on them on a regular cadence. And that has been a real positive for a lot of people. So we also 988 National Suicide and Crisis Lifeline. Last year, we put out a lot of education around this, around to all our outpatient and inpatient units, trying to get awareness out that 988 is available for anybody that needs a lifeline. And just in June, this is a national suicide and crisis lifeline. Just for this June, they've had 382,650 routed calls, chats, and texts. So it's a valuable resource. Average speed to answer those calls is 35 seconds, and their average contact time is 21 minutes with these people. So that are in need. So it's been a great success, and we're hoping to continue to promote that resource throughout the community.
Great.
And, that's all.
Okay. Thanks, Amy. All right. I'm going to turn it back over. All right.
Here we go. Sorry, I had a little internet glitch there, but I think I'm back with everybody now. Are you able to hear me okay?
Yep, I can hear you, and you just came back on the screen. Fantastic.
Perfect. So I would just tag on to Amy's information around zero suicide that we're really piggybacking on that effort with women's health and the family birthplace around screening for depression after delivery, depression and anxiety, because that's a high risk time for patients, and are doing very comprehensive care, both through our women's health practice and Barb's integration there, as well as at our family birthplace, screening 100% of those patients and making referrals as needed. And in the next HTP measure, hospital transformation program measure that I want to touch on is around opioid stewardship, which does have some overlap, obviously, with behavioral health. So three elements that I'll share around opioid stewardship and the good work that our opioid stewardship committee is doing is kind of an internal facing. I'll start with that, and then the education that's associated. So we're really monitoring and educating prescribers and clinical teams around perioperative opioid prescribing and pain medication in order to appropriately treat pain, while also minimizing patient exposure to and duration to opioid medications, which we know can present risk for opioid use disorder, as well as just number of pills that's available within our community, and the importance of limiting that volume that we've seen play out in our response to the opioid epidemic nationally. Similarly, our strong work through the emergency department is, again, to limit exposure for patients to opioids. And so we measure very carefully the number of opioids that we administer through the emergency department. So these two graphs, which are the most recent data that we have on file in our work through Colorado Hospital Association and through the state of Colorado for HTP, demonstrates, first on top is our rate of use per 1,000 ED visits of alternatives to opioids, or ALTOs, alternatives to opioids. So an example clinically of that might be to use something as simple as ibuprofen at appropriate dosing, rather than reaching first for an opioid in administration through the emergency department. Obviously, opioids still have their place, especially with traumas and fracture injuries and very acute, severe pain. But there's other types of pain that data has showed actually responds better to some of the alternatives to opioids. And I want to give another example there just to help kind of fill in this perspective. Sometimes that's actually counterintuitive. There's a medication, for example, called haloperidol or Haldol, and it's a sedative medication historically, while we actually have found it extremely beneficial for recurrent abdominal pain for certain causes, and far more effective even than opioid pain medication. So using something like that in the emergency department not only helps treat people's pain better, but also helps minimize those exposures to opioid and potential initiation of that chain of events that can lead to opioid use disorder. On the bottom, you see the graph of our opioid usage rate through the emergency department. So the big takeaway here is that you see our climbing rate of ALTO use over the recent months, and we expect that to climb further as time goes on here in 2023. So let's go to the next slide, please, where I wanted to just give an example of our patient-facing education around opioid stewardship. So fostering awareness both helps patients with recognition of how we appropriately treat pain, as well as reducing stigma, especially for those patients who may already have a condition like opioid use disorder, that we need to remove the stigma and really treat it as another medical condition, just like we do everything else, with compassion and empathy. So another example here is naltrexone that we hand out as free kits for patients at higher risk of opioid overdose. So naltrexone is a medication that is a reversal agent for opioids, often administered as a nasal spray. So if patients are on long-term use of opioid pain medication, or perhaps around a recent delivery of a child, we're giving all of those patients naltrexone because we know that's a higher risk time of life. And then at the bottom, you see some examples of our patient-facing education that we're working to put in place right now through our emergency department, and helping patients feel comfortable with our approach to managing pain while also reducing opioid exposure. And the final slide that we have for opioid stewardship really demonstrates our engagement with key stakeholders within the community, making sure that we're partnering rather than just doing this independently. So we recently this spring administered a survey to key stakeholders on what other community members and entities feel is most important for Valley View's position as a hospital to partner with and address specific concerns in minimizing opioid use disorder and treating those who may be afflicted already. Finally, the highlight that I want to end on with opioid stewardship here is our care coordination. If a patient is afflicted by opioid use disorder and needs medical management for that to reduce the likelihood of relapse, especially after a recent hospital admission, we will now have a dedicated staff member to assist with those transitions of care through a behavioral health advocate position in our inpatient areas. And I look forward to launching that in the near term this summer for through some additional grant money that Valley View was awarded, But really, this is a long-term commitment from Valley View for that enhancement of transitional care for opioid use disorder, as well as preventing opioid use disorder. So you can briefly see some of the responses we received from community stakeholders, which I won't belabor just for the sake of time. And I know we want to get to question opportunity.
Great, thanks. Thanks, Rob. So want to pause here. Leslie, if you can help, if there are any questions or comments in the chat, but then also open up the Zoom so that if anyone who's joining us, if you all have questions for Barb, Amy, or Rob, questions, feedback, are there things that, you know, again, as a community that we need to consider and discuss to further inform here at Valley View how we can move forward? Leslie, any chats or comments, questions in the chat?
No, pardon me. Can you hear me?
Yes.
I have a comment about Dr. Brooke Hallowell prescribing ibuprofen for pain management rather than opioids after a C-section, and had a great outcome, pardon me. The comment was, I really appreciate that as an option. That's my only comment at this point. I don't have any questions. Let me go back.
Okay. And is everyone off mute?
Everyone should be able to unmute themselves.
Okay. Okay.
Everybody is set up for chat, so.
And it looks like Ross Brooks may have had his hand up, so we'll make sure we go to Ross for the next question. As we do so, I wanted to just update the group. I think we did, I did have a typo in there in that naloxone rather than naltrexone is a medication referenced as the opioid reversal agent, brand name Narcan. So thanks for some feedback with that. Ross, are you able to speak?
Ross, can you hear? You should be able to answer live.
All right, maybe Ross had to step away. Anybody else?
I could speak briefly just to Ashley's comment. Thanks for
Please.
saying that. I think women's health, we've actually been working with a couple organizations at the state level to improve our awareness, our support of moms with opioid use disorder, substance use disorders. And through that process and that partnership with Moms Plus and the Colorado Naloxone Project, a couple other groups, I think it's really just raised our awareness as a provider group in general around prescribing, around substance use disorders. And we are actually giving all of our moms a dose of naloxone in a take-home kit when we first start working with them. And I think that the reception of that has been an amazing example of changing attitudes in the community related to substance use disorder. People love getting it, knowing about it, and feeling like they can help. I think it's exciting changes.
Okay. Thanks for that. All right.
So we may have a technical issue with attendees being able to come off of mute, it seems.
Give me 1 moment. I'm going to go in individually. And ask everyone to unmute, should they want to.
Hey, Rob and Stacy, it's Ross Brooks. Can you hear me?
Hey,
Yes,
we can.
Thanks,
Yay,
Hi,
Thanks
Ross.
for
sorry.
your persistence, Ross. Glad to have you on.
Thanks.
Awesome. Thanks for fixing that technical glitch. So hi, everybody. Ross Brooks, CEO at Mountain Family Health Center. I want to just elevate and compliment Barb Corcoran and the teams. I know Dr. Knaus as well in the practices, but the integration of physical and behavioral health is so key to what all of us do. So thanks for your efforts on behalf of the community. My question is more around what we collectively as a community are doing for the uninsured to help more folks get insured and to decrease total cost of care. So it looks like maybe Dr. Canals is about to hop into this or others are, but I want to set the stage for this, not in a blaming way, but to share that in 1998, when we opened Mountain Family Health Centers in partnership with Valley View, the uninsured rate in Garfield County was 16%. That's the same as what it is today, 25 years later. So we have a challenge as a community to try to help more folks get insured within our community and to make health insurance and care affordable. So that's really my question, and I'll leave it to y'all as experts to answer that in the future presentation.
Yeah, I think that's a great prompt, Ross. The second half of our talk today is kind of focused around access, including a big chunk of the content for addressing uninsured status and insured status of patients for that key access component. So we've got a couple of speakers to come, and I appreciate that prompt because I think it's going to set the stage nicely.
Yeah, so we'll just segue right in because yeah, obviously, Ross, the coverage, the access plays both into the physical and mental health of our community. So with that, want to pivot to the next need that we've prioritized to work and address, coverage and total cost of care. Again, you can see kind of the 5 primary strategies that are part of our community health needs assessment implementation plan. But I'm thrilled to introduce a colleague here at Valley View, Alejandra Sandoval, and she is part of our team that works really every single day with patients and community members to understand how they can get insurance and tap into other programs so that particularly as we look at improving coverage for vulnerable populations, we're addressing financial barriers to care. So I'm going to turn it over to Alejandra. And eager to have her join us. Can you hear us, Alejandra? I know you're on the phone.
Yes. Hello, everyone.
Hi.
We are trying to work with all our patients, like when they first come in. Let's see if they're coming into the emergency room or they've been admitted. We try and help the patients as soon as they come in. Like when they come into the emergency room, we go to the rooms and screen them. We have a lot of patients that they don't know about the programs that we offer. We work with Medicaid. We help them fill out the Medicaid applications. Sometimes those applications are hard or difficult for patients to fill out. We can help them fill out the applications, help them with the documents that they need to turn in. Same, we screen them for the hospital discount care, for CICP programs, and we also have our internal sliding scale that goes up to the 500% of the federal poverty guidelines. The soon as we can help the patients, they will come in and they're nervous. They're nervous that they don't have insurance. We let them know that there is assistance. That's something that they don't have to worry about. We can help them with all the resources that we can help them here at the hospital, turning in, like I said, applications, help them with the documentation that they need, especially now that a lot of the patients are getting off of Medicaid because of the end of the emergency pandemic. So a lot of them are going to lose their Medicaid benefits. There are other programs that we can help them with.
Okay. And I think you've got one more slide here, Alejandra. Let me see if I can toggle forward because I know also for those who are insured, there's also opportunities for conversation and help. Can you speak a little bit about that too?
Yes, there is even patients that have insurance. Sometimes they have a big deductible, or they're afraid that they're sometimes they don't want to do they don't want to pursue with their medical needs because they know that they have to meet this huge deductible. We can help them as well. All the programs are going to be, they can be secondary to their insurance.
Okay. And I believe this number here on the slide is the phone number to you. Is that correct?
Yes, that is my direct line, and I will be more than happy with any questions that they may have, any questions that they may have that they will call us. We have 4 financial counselors working 5 days a week that we definitely can be there for them.
Wonderful. Thank you. And then that link as well has additional background and information on the programs and the process. But it's wonderful to have a team with Alejandra and real people able to talk with community members and patients. So thank you.
Yeah, and
Now we're
I
going to,
would briefly highlight before
Yeah.
we move to the next slide, Stacey, I apologize.
No,
Just
you're
how this helps demonstrate Valley View's commitment to access, because we have made financial commitment to adding a significant number of staff members specifically for this need. Alejandra and the team that she works with have dedicated roles for helping patients enroll in various programs, all the way from Medicaid to CICP to our sliding scale programs. And anyone working in this area certainly can recognize the time and commitments that are required for helping individual patients. And this is super important for access in our community and ensuring that we have patients and community members who can get the care that they need at an affordable rate.
Yeah, great. So continuing on, want to talk about Medicare ACO REACH with an incredible legend in our community at this point, Dr. Gary Canals. Grateful for you to be here, part of this conversation, and for your continued work with Valley View and with for our community in this space. So I'll turn it over to you.
Thanks, Stacey and Rob. I've been listening to this, and all of the words that we have spoken so far, I think in a lot of ways are brought together with this REACH program. And, REACH is basically a government payment model that we are paid with now for Medicare. But really the importance of REACH is the work behind the scenes that it engenders and supports. And that's what I want to talk about a little bit. You'll recognize some of the things I talk about have already been talked about, but that's because they're the important part of the work that we do. If you go back 10 years ago, all of healthcare was paid for on a volume-based piecemeal basis. We've been trying every day, moving toward a value-based model to complement a volume-based model. And we talk about value-based care a lot. I ask people what's value-based care, and there are lots of different definitions. I want to look for a minute at what are the elements of value-based care that are important for our community and for our organization, and how we're working to accomplish that, and then come back to REACH at the end that explains that context. Value-based care. I've listed 6 things, and I'm not good with slides, so that they're not on any slides here. But the first is a primary source of care. We've developed a system of primary care practices at Valley View and in the community, and we know that people who have a primary care provider have better cost, better outcomes, better quality, and more patient satisfaction. The second is equitable access, and there's a lot of components to that. Equity is about reducing disparities in health, and part of reducing disparities in health is access to medical care. Medical care is only 10% of healthcare. The third thing is social determinants of health. And that's housing, and that's food security, and that's transportation, and that's mental health issues and trauma history, and all of those things that we need to be better at dealing with. A lot of time, the people with the greatest needs have the fewest resources. We don't know whether they are in that situation unless we screen. Barb talked a lot about screening. We screen for anxiety, depression, loneliness, frailty, substance abuse. All of those things are known to be associated with problematic access to healthcare. Behavioral health integration in primary care practices is important. Care coordination, we've talked about care coordination, that's important. And then wellness care. That's using that usual source of care to do a health risk assessment, to do a wellness exam, to walk out of the office with a plan for your health for the next year, whether it's about colon screening or mammograms or substance abuse or interventions for other things that we screen for. That's what goes on behind the scenes in primary care. And that's what REACH tries to support. REACH is a payment scheme. So we use the word scheme. Sometimes that sounds bad, but it's a payment system that restructures our reimbursement to pay us more for these value-based things that I just talked about, in addition to the volume-based payment that we get. We don't know what's the right balance between value and volume yet, but REACH pays us to develop infrastructure to be able to hire behavioral health providers, to be able to hire community health workers, that kind of thing. What's interesting is that I'm part of another organization called the Valley Health Alliance, and it's an integrated network of primary care providers from Parachute to Aspen. And I can say that almost without exception, the primary care practices in that REACH are all doing this work. They're doing it for 2,400 Medicare patients in Valley View, 8,000 Valley Health Alliance employees of local employers, probably 4,000. I don't have good numbers for Medicaid to correct this, but probably 4,000 Medicaid patients and 4,500 Rocky United patients. And so that value-based work is being done across those populations. And one of the things I think we've done well at Valley View is we take all comers. We are payer blind. And I think that improves equity, that improves access. And I think that makes a big difference.
Dr. Knaus?
Yeah.
May I ask, so if I'm a Medicare member in our community, do I have to do anything special to become part of this program?
So unless you have Medicare Advantage, and that's a totally separate program, you have been signed up for Medicare REACH. CMS automatically does that. So the 2,400 patients that I mentioned are all attributed to a primary care doctor at Valley View Hospital, and they are automatically enrolled in this program.
Great, thank you.
The extra things that REACH does, REACH stands for Realizing Equity, Access, and Community Health. That's what REACH works toward. We are all developing specific equity plans. We are expanding our screening to social determinants of health with every patient. We have done away with a 3-day hospital stay to go to a nursing home for people who need rehab or nursing home care for whatever reason. They don't have to sit in the hospital for 3 days just to take up space. We have increased ability to make home visits And, we don't have a home health agency any longer in this valley. And we find that our behavioral health folks and our community health workers are making home visits more and more to fill some of that gap, and REACH helps to pay for that. So that's sort of and in looking at it, REACH really brings together those elements of value-based care and helps that work better for all of us.
May I toggle to this next slide? Oops. Oh, I really messed up, didn't I? Here we go.
So next slide, that just sort of summarize on the left-hand side, talking about screening for social determinants and looking at demographics for equity and a waiver of the 3-day hospital stay. So,
Okay.
Yeah, thanks.
Great. Thank you, Dr. Knaus. And then last speaker to give highlight is Dawn Skulko. Dawn, are you there?
I'm here. I am broadcasting live from Estes Park, Colorado.
Fantastic.
I made a quick relocation to overcome some internet issues. So welcome to my truck. Thanks for joining, everybody, and thanks for letting me present. And that was a great introduction to my topic from Dr. Knaus. Thank you. Do you want to flip the slides, Stacy?
Do you see it?
It looks like it's on the not presentation mode from what I'm seeing, but that's okay because my slide doesn't really have anything on it, so I can just keep talking.
Okay.
I'm actually going to introduce a concept that is being worked on by one of Valley View's great partners in EMS Unlimited. If you're not familiar with EMS Unlimited, they are an ambulance transport company that has been in our area since 2019. They originally came and built a base and rifle to fulfill a critical need for transports in our area, specifically between healthcare organizations. So they aren't part of the 911 dispatch normally, unless there's a dire need, and that's a separate, but they're usually interfacility transports, meaning they bring patients from Valley View to St. Mary's, from Valley View to Denver, Valley View to any of the local skilled nursing facilities. And that's a really, really important need. I'd like to commend them. They have been very proactive in services that they provide, constantly looking ahead. They've added ambulances, they've added staff, they've added educational opportunities for their staff to be able to take care of transport higher acuity patients. And then on the opposite end, they also got a license to be able to provide non-medical wheelchair transports, which is also a great need and fulfilling a great need in our community for patients that don't need wheelchair or don't need ambulance transport, but can't really go in a private vehicle. This is another option, and we use it quite a bit for patients. Patients can sign up for it individually, and so it's been really an awesome opportunity. And again, they did all of this on their own. So the next endeavor that they are working on is also going to help fulfill a great community need. It's called the Community Paramedic Program. The entire purpose of the program is to connect underutilized resources to underserved populations. In this case, they're going to expand the role of EMS workers to provide health services where access can be difficult or sometimes doesn't even exist. Like Dr. Knaus said, we are definitely lacking home health services in our area. So this program is going to address that gap. There are a variety of general services that the EMS providers can perform, such as blood draws, vital signs, EKGs, wound care. They can also do some other educational and disease management. Can you guys hear me okay? Should have checked that a little bit. We good?
Yes.
Yes.
Okay. All right. They can also do some patient education and just general disease management follow-up. So some of those things are discharge follow-up, review of care plan, following up on medications, post-injury or illness evaluation, stroke, diabetes follow-up, asthma follow-up, nutrition assessments. These are all amazing services that can be performed in the home that will help keep patients out of the hospital, out of the emergency department. It doesn't have to be just the hospital to connect them to these services. Our primary care providers in the area will also be able to connect them to these services. They are mirroring the program that Eagle currently has for their community paramedic program. If you want to check out, they have a great website that lists all the services and how they function. The Eagle County Paramedic Program has an entire grant that funds all of that, is funded through a grant. And EMS Unlimited is in the process of applying to be able to do this service in our area, and they hope to have it up and running by the end of the year.
Wow, that's exciting. What great news
It is.
to bring to this
Yeah.
conversation, Dawn. Thanks.
Yeah.
Yeah, and I guess we just highlight the essence there of the collaboration with Valley View. Certainly EMS Unlimited deserves just immense credit for taking this initiative, being proactive, and really working towards what we've seen as best practice models nationally. And I would say Eagle County is on that forefront. But I think Valley View and EMS Unlimited have a unique relationship in that a lot of patients from Valley View, rely on those EMS Unlimited services, and we want to, leverage our positive relationship to work together as community key stakeholders and expand the reach. That's going to benefit the patients first and foremost. And it's also going to, streamline services for EMS Unlimited and the quality of care that Valley View delivers. This is going to, in our aim, help reduce readmissions, especially for higher risk patients, especially in the void that we've recently experienced with the lack of home healthcare services, as Dawn mentioned. And, really the sky's the limit for the things that we can help with those patient touches and around transitions of care, whether that's kind of more standard discharges or even something related to more complex needs like treatment of opioid use disorder. So we really look forward to the coming timeframe for our collaboration with EMS Unlimited, and happy to take any questions on this topic.
Yeah, so Dawn, you were our final showcase, but wanted to again, I'll stop sharing my screen, but again, just ask Leslie for her help to look at the chat, to open up any mutes, to see if there are questions, comments, feedback for Dawn, Dr. Knaus, Alejandra, as we look at not only Valley View, but our community coming together to address access and total cost of care.
At this time, I don't have any hands up or questions or anything new in the chat, but we'll maybe give it a second and see if.
Stacey, I would just jump in real quick. Just this is Gary. One of the ways, and all of these things talk about that, but one of the ways we talk about complicated patients is through the medical model. Complicated patients have this heart procedure or this whatever, and we look at it by the number of diagnoses they have. The complicated patients really are the patients with a lot of what I call messy details. And messy details are those social determinants. This morning in our care management meeting, we talked about 3 patients who couldn't get to Valley View Hospital, either their transportation or their gas, or they have a disabled child at home that they can't arrange for. Those are all the messy details that people have. Decreased access, increased needs, they've got opioid issues, et cetera, et cetera. Those are the folks that these programs really help. And this EMS thing is really intriguing. It doesn't need to be, we need to work as a community.
Yeah.
I would just add that I've been in this for 25 years, which in this group is not that long because there's lots of experience here. But I started on the inpatient world, and I just remember back then not care from the inpatient side to the outpatient. And I think this meeting and everything that we've just described is really the essence of the coming to fruition, where we are really connecting the healthcare across the entire community.
Great.
That's our goal.
Yep. All right, just pausing for
You
any
don't have
feedback,
anything yet?
questions. Okay. Well, we are all here. One of the wonderful things about working in this community is to see on the line so many familiar names, incredible leaders in healthcare and the business world. So thank you for attending today. Thank you for all that you do. Know that each of us are just a phone call away. Most likely we will run into you at the grocery store. But again, this is one of the beautiful things as we talk about these profound needs in our community, that we do have this opportunity to link arms across the Valley View network of care, but across this entire community in this region to really impact and improve community health. So we do want to hear from you. If you go away from today and think about things that we should be considering, ways to just work better together, please don't hesitate to reach out. But as always, we're grateful for your time today to be part of this town hall. And thanks for all that you do. Okay. And with that, we'll say goodbye. Thanks,
Bye.
everybody.
Thanks, everybody.
Thank you.
Thank you, Stacy.